Hello, everybody. Thank you so much for coming. My name is Brooke. This is Brittany, and this is Kelsey. We're actually all diabetes educators at Helen DeVos Children's Hospital, and we're so excited for you to join us for our presentation today. We are Helen DeVos Children's Hospital. We are the largest children's hospital located in West Michigan. This is our clinic FTEs. One thing to note is we actually have a 1-to-1 ratio of endocrinologists to diabetes educators, so we have 8 and 8 of those. Among our type 1 diabetes population, we have about 1,700 patients that we serve. Of that, in the year 2024, we had about 285 new onset patients, and among those total, we have about 30% of them that have public insurance. Our goal was to improve the use of hybrid closed-loop pump use among our patients to 75% by June of 2025. We created this fishbone model to highlight some of the barriers to hybrid closed-loop utilization. I recognize there are a lot of words on here, so take it in and go on to the next slide. From there, we created this key driver diagram. The bolded, highlighted areas are the interventions that we chose to create PDSA cycles for. We are going to go into more detail on the following slides. One thing to note is that while our aim was generalized to our total patient population, we did really feel that most of the barriers that we identified in our fishbone were really targeted more at those with public insurance. So that is kind of what we decided to focus on with our PDSA cycles. For our first PDSA cycle, we focused on insurance coverage advocacy. We started this in October of 2022, and this is still an ongoing process. We really did identify that there was oftentimes limited coverage among Medicaid plans in particular, and that did reduce access to those patients pursuing hybrid closed-loop pump. One thing that we started off doing was creating a standardized letter outlining the medical necessity for hybrid closed-loop pumps. We also utilized our amazing prior authorization specialists who helped submit these authorizations along with supporting documentation, and that really helped us to secure a great amount of successful PA approvals, both in commercial and Medicaid plans. Another thing that we did is we worked very closely with managed Medicaid plans to help advocate for coverage for the Omnipod 5 in particular at the pharmacy level. 2 plans that we worked with very closely were Priority Health Medicaid as well as Meridian Medicaid. During this process, we were having just lots of prior authorizations that we were submitting for and getting approvals for, and that allowed us to justify hiring of a pharmacy tech to help kind of offload this burden on our singular individual prior auth specialist.
For PDSA Cycle 2, we wanted to focus on standardizing our pump education process. Previously, patients had to come in for a 2-part insulin pump class, starting with a saline start and then a week later coming in for an actual insulin start. We found that this was really difficult for families to get time off of work, and there was lots of burden from loss of income, particularly for our Medicaid population. So we decided to change to a single insulin-only pump start class, which really improved the number of patients that were able to get onboarded to pump therapy. We also worked to standardize our communication leading up to the pump class to ensure successful onboarding, avoiding patients not having the correct supplies or equipment necessary to get started and having to reschedule. We also found that patients not only couldn't attend the pump class, but they couldn't attend the classes leading up to the pump due to the similar things of loss of work and income. And so we actually worked to pre-record our live virtual classes so that patients were able to access those at a time that was conducive for them to ensure that they were able to also get onboarded with pump therapy. For PDSA Cycle 3, we found that many patients couldn't access hybrid closed-loop systems due to not having access to a mobile device. So with a very lengthy approval process with our legal team, we were able to create a device drive, and we were able to secure 5 mobile devices through donation purposes. We also created criteria for patients to be eligible to receive these devices that you can see listed here, particularly focusing on our patients in the Medicaid population. Once they started on the systems or were identified to be able to start on system, they also were completing a quality of life survey that we created with plans to follow up quarterly. We found that it was inconsistent in patients completing these, forgetting to do it, as well as inconsistent caregivers to bring them to their follow-up visits. So ultimately, we didn't get much valuable information from this. We did see a pretty successful improvement in time in range and A1C for the 5 patients, with the exception of one outlier patient there. However, in January, Omnipod 5 integrated with Libre 2 Plus, as we all know, and so that essentially negated the need for a mobile device for many of these patients. That combined with inconsistent phone donations, we decided to kind of no longer do the device drive at this time. Our last PDSA cycle, starting in November 2024 and ongoing, we found that there was a bias with the providers to actually prescribe the pump, as well as a bias for patients to understand the education or get the education to know the benefits of hybrid closed loop systems. Previously, we used an opt-in approach, meaning that patients were completing the required diabetes education classes and then had to reach out to us to ask to initiate pump therapy. We inconsistently talked about it at follow-up visits, as well as there was not really good consistent criteria for who was eligible for pump therapy, and this led to significant delays. So we switched over in November to an opt-out approach, meaning that all patients were on path to pump unless they chose otherwise or didn't meet criteria. So we scheduled all of our patients for our intro to pump class with the 3 required classes from the start, knowing that this was standard for them and best practice. All patients were also started on CGM therapy at diagnosis, and providers were required to talk about pump therapy at their first follow-up visit. We also created a specific criteria for patients to be eligible to start on pump. They had to be wearing a CGM consistently, attend all of the required classes, and attend their first follow-up visit. Not only did this increase the number of patients starting on pump therapy, but it also significantly increased the time, or decreased the time from beginning of diagnosis to starting on pump, and most of them getting on pump within 6 to 8 weeks of diagnosis.
So as you guys can see, the results of our study showed that total hybrid closed loop pump utilization increased. Particularly, we saw baseline shifts related to those PDSA cycles that we implemented. You could see those there. We met our goal of 75% total population on hybrid closed loop pump in July of 2025. And around May, we started to see the beginning of another shift that's not pictured here. And right now we are at about 79.8% patients on hybrid closed loop pump therapy as of October. So diving deeper into this data, we looked at hybrid closed loop utilization by payer. And so a combined private and public payer relative improvement in green, we saw that at 39% improvement, and this was statistically significant. Separately, privately, we saw 40% improvement in those insured patients, and then 35% improvement in our Medicaid population. However, this was not statistically significant. And this did kind of distress us because a lot of our PDSA cycles were focused on this population. And so we'll talk about that in a second. Something else that was pretty interesting that we didn't initially think to look at, but we looked at after the fact was A1C. And so over the study period, our median A1C decreased by 0.5%. And this was really great. We also saw a really beautiful narrowing of variability over that period of time. Okay, so limitations. Again, going back to that, not significant Medicaid payer hybrid closed loop pump utilization. When we looked a little bit deeper into our T1D portal, we saw that looking at the payer population, 30% of this population was listed as unknown payers. And so we think that maybe we weren't coding something correctly in that portal. We'll definitely have to look into that. And we think that this definitely skewed our data in improvement by payer.
Something also important to note was that we did not differentiate during our project the difference between pump initiation and ongoing pump usage. And so knowing this, future considerations, we're definitely going to look more at barriers to staying on pump. Some particular ones that we find in our specific clinic are making sure that they're getting supplies, coming to appointments. Maybe we don't offer additional education after pump therapy, so that's something that we're going to be looking into. And that is all. Thank you guys for listening. Do you have any questions for us?
Thank you. That was great. And I think that 35% improvement, even without it being, statistically significant, is amazing.
Yeah.
All right. Questions right here.
Yeah, that was really fantastic, impressive outcomes at the end. I was just curious, your device drive, the donation thing, could you speak to that a little bit more? Did you have people in your practices donating, or you went through another company?
The dream was to be able to kind of share it publicly to try to get people who have devices laying around, because y'all know we have one that we've upgraded and it's just sitting on the counter in a drawer somewhere. So that was the dream to get to, but we wanted to start small. So we actually had a donor who specifically allotted donation money to be able to purchase a couple of devices. And then we had an amazing practice manager who also had a partnership with her husband's employer, and they provided us with several of their phones that they were no longer using because they upgraded on a consistent basis. So that's how we were able to secure them. So we definitely want to look at how do we secure ongoing, especially after hearing that wonderful remote patient monitoring conversation. So,
any other questions?
That was great. A process that I've been working on for a while is increasing our pump use, and the class has always been an issue. So just curious, are your first 3 classes, like I see generic diabetes, like how to make dose adjustments, that sort of thing, and then the 4th class is your pump class. Is that an option to do in person or virtual, or did you just go to the virtual pre-recorded?
We actually do not do any in-person classes unless it's designated as needed, such as like a language barrier, etc. Otherwise, all of our classes are done through Microsoft Teams virtually, and then we pre-recorded through something called Vimeo to allow patients to be able to watch those at a different time. The barrier with that is at this moment in time, we can't charge for that education. That's something we're working on with our team, because that's unfortunate that we can't capture that when they're getting the same exact education. It's just recorded. But we still wanted to give them that access.
Thank you.
Yeah, of course.
So in addition to that, how are you monitoring that they actually watch the video? Is there like a knowledge assessment attached with that?
Yep. They are all completing a quiz, the same quiz that we do with our live class as well as the pre-recorded. We assess their knowledge at the end. Obviously, they could also be sitting in a live class and not really be paying attention, so we can't guarantee, but if they're answering at least a passing score, we consider them as attending.